A user named Ash sent us a DM asking to learn more about disseminated intravascular coagulation, or DIC, and its clinical significance in veterinary medicine. So today we are going to explain how this life-threatening syndrome causes excessive clotting and bleeding at the same time. Feel free to send us a message via DM of topics you want us to do next or to donate to our game and video development. DIC is not a primary disease. It develops secondary to severe conditions such as sepsis, heat stroke, pancreatitis, immune-mediated hemolytic anemia, neoplasia, major trauma, gastric dilatation volvulus, envenomation, liver failure, or obstetric complications. To understand DIC, let us quickly follow the part of the coagulation cascade that becomes abnormally activated. Inflammation and endothelial injury expose tissue factor, which binds activated factor 7. The tissue factor, factor 7 complex activates factor 10, and can also activate factor 9. Activated factor 10 combines with factor 5 to convert prothrombin, or factor 2, into thrombin. Thrombin then converts fibrinogen, or factor 1, into fibrin, while factor 13 crosslinks the fibrin into stable clots. Thrombin also amplifies coagulation by activating platelets and factors 5, 8, and 11. In normal hemostasis, this reaction remains localized to an injured vessel. In DIC, tissue factor and thrombin generation become widespread throughout the circulation, producing fibrin microthrombi inside small blood vessels. These clots can obstruct perfusion to the kidneys, lungs, liver, gastrointestinal tract, and brain. Platelets, fibrinogen, factors 5 and 8, and other coagulation proteins are consumed faster than they can be replaced. Antithrombin and the protein C anticoagulant system are also depleted or impaired, removing important brakes on thrombin production. Plasmin then breaks down fibrin, producing fibrin degradation products and D-dimers. But this fibrinolytic response can further contribute to bleeding. Clinically, an animal may initially show signs of the underlying disease, including fever or hypothermia, tachycardia, weak pulses, hypotension, respiratory distress, abdominal pain, altered mentation, or decreased urine production. As DIC progresses, petechiae, bruising, bleeding from venipuncture sites, epistaxis, hematuria, gastrointestinal hemorrhage, body cavity bleeding, or multiple organ failure may develop. There is no single test that confirms DIC. Diagnosis depends on a compatible underlying disease combined with changes such as thrombocytopenia, prolonged PT and APTT, increased D-dimer or fibrin degradation products, decreasing fibrinogen, reduced antithrombin activity, and schistocytes caused by red blood cells being damaged as they pass through fibrin-filled vessels. Fibrinogen may initially remain normal or increase as an inflammatory protein, so trends are often more useful than one measurement. Early hypercoagulable DIC may also occur before PT or APTT becomes prolonged, making serial testing, thromboelastography, or rotational thromboelastometry valuable. Treatment begins by aggressively controlling the trigger, such as administering appropriate intravenous antimicrobials and obtaining source control for sepsis, cooling a heat stroke patient, or treating pancreatitis, trauma, or immune-mediated disease. Perfusion may be supported with carefully reassessed boluses of a balanced isotonic crystallate such as lactated Ringer's solution, Plasmolite A, or Normasol R. An actively bleeding patient with consumed coagulation factors may receive fresh frozen plasma at approximately 10 to 20 milliliters per kilogram intravenously. Plasma supplies coagulation factors and some natural anticoagulant proteins, while packed red blood cells may be given when hemorrhage has caused clinically significant anemia and impaired oxygen delivery. Unfractionated heparin is not automatically indicated for every DIC patient. It may be considered undocumented early hypercoagulable or thrombotic DIC before severe bleeding develops. A commonly proposed dose for dogs and cats is 50 to 100 international units per kilogram subcutaneously every 8 hours. But veterinary dosing is not fully standardized and should be adjusted through close clinical and coagulation monitoring. Heparin binds antithrombin and greatly increases antithrombin's ability to inhibit thrombin and activated factor 10, reducing continued fibrin formation. It does not dissolve existing clots, and because antithrombin may already be depleted in DIC, its effect can be unpredictable. Heparin is generally avoided in severely hypocoagulable or actively hemorrhaging patients because it may worsen bleeding. The major takeaway is that DIC is uncontrolled activation of the normal coagulation cascade followed by consumption of the platelets and factors needed to stop bleeding. Survival depends on recognizing the condition early, monitoring how it changes over time, supporting perfusion and oxygen delivery, replacing blood components when indicated, and rapidly treating the disease that triggered it.